from other clubs throughout the country are also joining in. Could we just ask that everybody mute their mics because we have some feedback coming through. I want to especially thank the Rotary Club of Spanish Town for not only arranging but for inviting all Rotarians to join in this very important session where we will have a chance to not only hear from but to speak with our own CMO with regards to the pandemic that we are all facing together. But I think Rotarians this evening, you'll agree with me that this occasion where we have not only a joint meeting, but we have Rotarians from right across the country, that it is one that really fits in well with our Rotary tradition, and that is one of fellowship and camaraderie. And I must say that I am very pleased with what we have been able to do under these very trying circumstances as Rotary. And I'm sure you will agree with me also that we have only just begun and that there is a lot more to come, because service above self has no regard for a pandemic. In fact, it is during these challenging times that Rotarians step up to the plate. So I want to say thank you again on behalf of all Rotarians, but more specifically on behalf of Jamaica Central, that you made the time to come and join us. Please enjoy the meeting, and I would like to just turn it back over now to President Latoya. Thank you so much.
Thank you very much, AG Yasmin, for that greeting. And we're moving to President's time. For President's time, I'll be very brief because, as I said again, we want to have as much time with Dr. Bissasor-McKenzie as possible. So I want to really thank all the presidents for ensuring that we have this joint meeting, and I hope that it will be the first of many joint activities between the clubs. Coordinating was very easy because we do most things online now, and I think it provides an opportunity for us to share knowledge, share experiences on an ongoing basis and on a frequent basis, so that this experience, although unique, this year, we can find opportunities in this experience. Just by way of one reminder for my club is that I want to encourage everybody to start thinking about that will put on the table so that we can get that squared away by the end of the month. We are in the last meeting for September and moving into October. So I think that submission needs to go in by the 31st of October to the district. So just for persons to start thinking about that. But I don't have much. So at this point in time, I will now turn over to PAG President Shirley from the Rotary Club of Portmore.
Good evening again, fellow Rotarians and guests. Like our President Latoya, we're so anxious to hear the presentation. My president time will be very brief. I just want to say that the Rotary Club of Portmore has done so much in this pandemic time, and it amazed me of the things that we have done since the start of August. And for this month, in celebrating our basic education and literacy. I am proud of my club, and I just want everybody to know that I am really, really proud of the Rotary Club of Portmore members. And we will continue to make Jamaica Central what it ought to be. I've spoken to our AG, Yasmin, and I said to her, we are going to make her a proud mama. And I hope that my club members will continue to work, because I know they are rearing and ready to go. And as a member of Jamaica Central, I'd also like to work along with my other club, my other Jamaica Central clubs. I just want to say thank you.
Thank you, President Shirley. President Nicholas.
Hi, good evening, Rotarians. Are you hearing me?
Yes, we are, Nicholas.
All right, all protocols observed. Good evening again. I bring greetings from the Rotary Club of North St. Catherine. I just want to thank President Latoya and the Rotary Club of Spanish Town and other presidents for facilitating this meeting this evening. For me personally, and also my club, it is an important one, having the Chief Medical Officer to chat with us a bit. From a personal point of view, I am looking forward to hear from her, someone being intimate with COVID-19. So I just hope and I pray we have a good meeting that's very informative. And I just want to wish everybody a good meeting and keep safe. All right, back to you, President Latoya. President Latoya is still there?
Sorry, I was muted.
Okay.
President Noblet. Thank you, President.
Good evening, President Latoya, fellow Rotarians, and our own AG Yasmin. Thank you for the opportunity on behalf of the Rotary Club of Manor Park to be a participant in this very important discussion this evening. Just want to say that the Rotary Club of Manor Park did not have to make too much of a step change with the advent of COVID in terms of how we do our business, because we were always online. As a matter of fact, you could almost say we are online with each other every day, sharing ideas, information about activities, projects, and the things that we have been doing and are intending to do. So we have, as a club, I think we have great spirit, great heart. We're not huge in numbers, but I think our cooperation and our team spirit has, helped us to be where we are today. So for those members who have, based on job commitments, who have been unable to join us on this Zoom, they're here with us in spirit. That we have been getting questions and regrets in our chat, our apologies for not being here because they are otherwise occupied in meetings. So I think AG Yasmin and myself and whoever will join us later on, we want to thank you on their behalf for the opportunity. Thank you. Back to you, President Latoya.
Thank you very much, President Noblet. And thanks again to all the presidents for encouraging your club members to join this very important meeting. At this point in time, we will move into the introduction of our guest speaker, and we'll ask PP Mike Norton to do that. PP Mike.
Thank you, President Latoya. Good evening, fellow Rotarians and guests. Special good evening to our guest speaker, who is Dr. Jacquiline Antoinette Bissasor-McKenzie. She is the Chief Medical Officer of Jamaica. Dr. McKenzie started her formative education at Glenmuir High School in 1977. and her secondary school training. And I have to say this, fellow Rotarians, as a St. Jago alumni myself, was completed at St. Jago High School in 1984. Thereafter, she went to the University of the West Indies, doing a number of courses of study, including a Bachelor of Medicine, a Doctor of Medicine, and a Master's in Public Health Administration. Several of these achievements, she graduated with distinction. In terms of professional certification, she has numerous, including Advanced Cardiac Life Support, Advanced Trauma Life Support, Incident Command Systems, and then in-house training, in clinical auditing. Other academic pursuits included at the American Heart Institution, where she was awarded a Certified Advanced Cardiac Life Support Instructor, the Heart of Jamaica, and she was also in 2008 through 2015 an examiner with the Doctor of Medicine program at the University of the West Indies. Today, she, as I said earlier, is the Chief Medical Officer of Jamaica, but she has basically several achievements under her belt, including medical officer at the Spanish Town Hospital. She had her general practice in Brayton, University Hospital, Chief Resident Emergency Medicine, Spanish Town Hospital, a consultant in emergency. She was a consultant emergency physician. She was the Director of Emergency Medical Services in the Ministry of Health, the Principal Medical Officer, Director Emergency Disaster Management at the Ministry of Health, and in 2018 to present, she has been the Chief Medical Officer of Jamaica. Over the years, Dr. Bissasor-McKenzie has been President of the St. John the Baptist Preparatory School PTA, President of the Jamaica Emergency Medicine Association, and Vice President Jamaica Emergency Medicine Association in 2007 through 2008. She has participated in multiple conferences and teaching presentations all over the world, too numerous to mention. Looking through quickly. Board member of the Medical Council of Jamaica, Cannabis Licensing Authority, the Hazardous Substances Regulatory Authority, University Hospital of the West Indies, and the Specialty Board for Emergency Medicine at UWI. She is chairman of the Quarantine Authority of Jamaica and the Central Board of Health. She has represented Jamaica at the United Nations high-level meeting, the World Health Organization General Assembly, the Commonwealth Ministers of Health meeting in 2018-2019 in Geneva, Switzerland, PAHO, Pan American Health Organization Council meeting 2018-2019, the Council on Health and Social Development CARICOM Health Ministers meeting 2018-2019, Joint External Evaluation Exercise in New Zealand at the International Health Regulations, the G20 Health Ministers meeting, Mar del Plata in Argentina in 2018. Dr. McKenzie is married and has 3 children. Fellow Rotarians and guests, please join me in welcoming our guest speaker, Dr. Jacquiline Antoinette Bissasor-McKenzie.
Hey, thank you. Thank you for that introduction, and thank you for inviting me to attend your meeting. I guess a special thanks to Dr. Brown, who I could not have said no to, he been my former boss. So I was not able to say no, even if I wanted to say no. So thanks to Dr. Brown for having me here. So I've been told I have 15 minutes to speak very briefly. I was told to say where we are in terms of the COVID pandemic and our projections and what can Rotarians do. So I'm just going to dive right in since I have a short time to leave time for any questions or discussions. Well, it really is just my fate. I don't know if it's terrible or not that I happen to be the chief medical officer at this time. But you know, I don't think we're going to see another pandemic for our lifetime. Well, I certainly hope not. So it is really also a privilege to be in the position at this time and to be able to lead the health sector in terms of our response. Now, just want to go quickly into where we are. So WHO has defined 4 transmission scenarios for COVID-19. The first transmission scenario would be where you have no cases. And the second would have been sporadic cases, where you would have areas within your country with 1 or more cases, either imported or locally detected. And then you would go on to cluster of cases, where you would have areas experiences cases clustered in time. So maybe 2 or 3 persons arising out of 1 index case. And so you would have this in different geographic locations, and you would have had a common exposure that would have led to these clusters. And then you have community transmission, which is the 4th phase, where you have countries, areas experiencing larger outbreaks of local transmission, defined through an assessment of factors, including, but not limited to, large number of cases that are not linkable to transmission chains, and large number of cases that are coming out of our in-country respiratory surveillance from our sentinel sites, and multiple unrelated clusters in several areas of the country. So in terms of Jamaica's journey, Jamaica started actively to monitor what was happening in terms of the onset of a new infection, a new virus that was affecting China at the time in January. And as early as January 20, we had started to sensitize the public. I think we put our first full-page ad in the paper on the 20th of January, speaking about this new corona or novel coronavirus, as it was called at that time. January 31st, everyone will remember, was when we had put in the travel ban on persons coming from China. And at that time, we had no cases. On March the 10th, we reported our first imported case. And this was shortly followed, I think it was March 11th, that the pandemic was declared. After we start having 1 imported cases, very shortly, in a very short period after that, we would have picked up other imported cases that eventually led to the restriction of entry into country. In April, we would have seen that we had 1 large cluster of cases that pushed up our numbers dramatically. And we thought at that time that this was the worst of it, because we were able to manage that and we were able to bring down back our numbers. In May, we started to open up a bit in terms of our borders. So we started to let in the cruise ship workers, and we admitted over 1,000 cruise ship workers at that time, and we had small arrivals of other persons in country that were stranded in other parts of the Caribbean. So in May, following on this importation of cases, we would have started to see some cluster of cases that were now arising out of cases that would have come into the country in March, April, and May. In June, we opened up further to Jamaicans that were stranded overseas, and we admitted persons that were Jamaicans between June 1 to 15. And after that, on June the 16th, a decision was made to open up to non-Jamaicans who would come into the country. And coming up to, for the period of June, I think we had about 5,000 persons that came into country. And then we went into July, still admitting persons that were coming, persons that were coming from all over the world, non-Jamaicans. And we had about 13,000 persons that came into country in that period. Now, what was happening at that time was that a large number of cases were coming into country, and while it was that persons were placed under quarantine and were being monitored, we would have seen that we started to have an increase in the number of clusters of cases. So we would have seen clusters right across the country, but these were small clusters. We responded in terms of our public health interventions in several communities, and we were able to cauterize those incidences. However, based on the large volume of persons that were coming in, we would have had quite a number of undetected cases that would have been in country, that would have risen to a situation where at the end of July, we would have seen those large clusters coming out of St. Thomas and Clarendon. And at that time, we were closely monitoring, along with PAHO, WHO, the situation in country. And having had our discussions with PAHO regional office and local office, we concluded that we were at that phase, still in the phase of cluster of cases, because the cases were more or less confined to Clarendon and to St. Thomas, those large outbreaks in those two parishes. However, as August went on, we would have noticed that we would have seen, with first of all, the Independence weekend, we started to have a slow decrease in the restrictions, and we would have seen coming out of that considerable more exposure, that we would have started to see our numbers steadily climbing. And by the end of August, we would now have identified that what we had seen in St. Thomas and in Clarendon, we would have been seeing similar increase in numbers in various parts of the country, in most parishes. And so again, we would have proceeded with our discussions internally, analysis by PAHO, WHO, and would have arrived at the conclusion that at this point we were in community transmission. Now, what does community transmission mean? What it means is that there is the assumption now that there are several cases in several communities that are not known. And so these persons form linkages to cases that we would be picking up through respiratory surveillance. These persons would have gotten ill, would have presented to their health centers, to their hospitals, and would have, by virtue of becoming a suspected case, having respiratory symptoms, fever, would have been tested and would have been found to be positive. But there could be no link to say that this person got it from a known confirmed case or a known imported case, because there would be several cases that were undetected who would have been transmitting disease without their own knowledge or the knowledge of the persons that they would have been passing it on to. So that situation would be right across the country now, meaning that the assumption is that everybody, there is a possibility that that person has COVID, and therefore now everybody needs to protect themselves to slow transmission and to protect the vulnerable persons in the population. Now, when we came to this point of saying that we were in community transmission, there was a lot of disappointment by a lot of persons. Some people, there's a sense of failure, both within the health sector and outside, to say, have we failed? Why it is that we have reached community transmission? I don't think that we should see it as a failure, because the fact is that in a country like Jamaica that depends on travel and trade, we have probably more than our population that is living in country that lives outside of Jamaica, and that there is considerable travel between Jamaica and different countries. So was it inevitable that we would eventually have reached to a point where we would have a significant volume of positive persons in country, that we would start to see what looks like an exponential spread? Now, initially, we had looked at the numbers very early and had looked at our projections based on what had happened in 2009 with the H1N1 pandemic at that time. At that time, Jamaica was not so severely hit as it is now, but we were able to look at those numbers to see the amount of persons that were affected. And that number of persons that were affected would have been by projections, would not have been by persons that were tested, but by looking at the number of persons that would have had symptoms, and then the percentage of those that would have been tested and found to be positive, and working your way back to say really and truly what amount of the population would have been infected, known or unknown, to have given rise to these numbers. So it's really a backward tracking of the numbers to see what could have been the volume of persons that were affected. So even when we make a projection that nearly all of our population would be eventually affected by COVID, that projection is based on the fact that not everybody is going to know that they have COVID. Not everybody is going to have symptoms. Majority of persons that have symptoms will have only very mild symptoms, and a smaller number of persons would get ill enough that they would need to be seen in a health facility, and even a smaller percentage of those persons would need hospitalization, and a smaller percentage of those persons would have more severe illness, and some persons would die from this disease. So this projection had been made early, and when we had looked at those numbers and we looked to see what was the projection in terms of the use of ventilators, the use of beds in hospital, the health sector, of course, would have started to prepare, not just for the present phase that we would have been dealing with at that time, but for the eventuality that we would reach to a point where we would need those beds. And so we had gone into the process of procurements of spaces for the management of persons who would need high dependency care. We had gotten our hospitals to identify spaces in each hospital. We would have gone through the activation of our planning and coordination mechanisms. We would have enhanced our surveillance following the WHO protocols and increase our monitoring across country. We would have put in place various containment measures in terms of quarantine facilities, isolation facilities, and we would have done our hospital preparations in terms of the increasing awareness among healthcare workers and the preparation of spaces. And of course, most importantly, our communication program that right from the start we would have. So we are at this point now. We have managed the pandemic so far in what I would like to think of as 3 different spaces, in terms of, first of all, the port of entries, where our presence was very visible and everybody knew we were managing COVID because it was clear we were at the airport, people were seeing us. When we went into cases in the community, with all the community interventions that we did, again, very visible. People were seeing us in the communities. Certainly the minister was out there. we were heavily involved in the community surveillance. And now we've reached into a different space where our focus is on our health facilities. So while it is that we have to continue to maintain our strength at the ports of entry and in the communities, our main focus at this time is in our healthcare facilities. That's not going to be so visible in terms of the work that we're doing, but this is a very intense activity, because what this means is that every single day, certainly from the central level, we have to monitor every single hospital. We have to monitor every single bed. We have to keep a check on every confirmed, every suspected case that is in hospital, see when the numbers are rising, and put in interventions to bridge those gaps that are there, movement of patients to other hospitals, expediting testing to get patients out from suspected to confirmed or not confirmed to get patients out of hospital. It's certainly a very, very intense set of activities at this time, because every single day this has to be monitored so that we can respond. But it's not something that is visible, like you would have seen us at the airports or in the communities. And so many persons say that we have dropped our hands. But, you know, for me, this is the hardest part of it, because the engagement of healthcare workers, the management of personal protective equipment, the trials with the testing, all of this now becomes more intense as we have to manage and to try to prevent persons from moving from that moderate to critically ill to severely ill, to needing a ventilator, and to ensure that the health system is able to respond. So there is that, as I said, there is that sense that we have dropped our hands, but I just want to reassure persons that that is not so. It's not, our activities may not be so visible, but it's just as intense. It's more critical at this point. Our efforts really are concentrated in facilities. However, we do recognize that at this point, we do need to concentrate on keeping the population engaged and decreasing the exposure to the vulnerable. So while we focus our activities at our new battlefront in the hospital, we still have to maintain our position at our ports of entry and in our communities. So we still have all of these areas of focus, and then most importantly, the strengthening of the health workforce, and strengthening not just in terms of numbers, but strengthening in terms of increasing motivation, attention to staff welfare, to improving staff morale. All of these things we have to focus on at this time in order to ensure that we are able to keep the country in a good position. And you know, we see the number of deaths at this time, and it's frightening for many people. And we see that the number of hospitalizations are increasing, and that's also frightening. But when it comes down to what the population needs to do, it pretty much remains the same in terms of the general measures that persons need to take. The general measures that really are going to keep yourself and your loved ones out of hospital: hand hygiene, respiratory etiquette, social distancing or physical distancing, and environmental cleaning. These are still the basic principles that we have to adhere to in order to ensure that we can protect ourselves, vulnerable in the population, and the rest of society. I just want to finish with one last comment in terms of what's happening in terms of mental health in our population at this time. Right now, a lot of anxiety and fear. Sometimes it's very, very difficult to strike a balance as to what it is to say, because people want to know what's happening in terms of hospitalization, what's happening in terms of deaths. But then at the same time, some people are saying, should we be saying it? Because it scares people. But then do we need to scare people a little to make them compliant? Or should we not? Somebody said to me today that we should not be telling persons that persons with comorbidities are persons who die. But then if we do that, would we not be doing an injustice to the persons who have these comorbidities for them not to recognize their risk? You know, it's so much of a balance, how it is that you relieve anxiety and relieve fear in the public. And of course, communication is one of the big areas where we have to do a lot of work in order to be able to get people to know what is happening, hence meetings like these, you know, so that we can address some of the issues that make you anxious. There are other things that are contributing to mental health problems in terms of a lot of households have become unstable because of loss of income, because we have asked persons to stay home, we have increased curfew hours, we have put in a lot of restrictions on entertainment, on various activities that would occur after 8 o'clock, restaurants not doing well, fast food places that need to close early. There's a lot of loss of income from a lot of people, and that contributes to persons becoming very anxious and leading to mental health issues. The loss of routine. Many persons are used to doing certain things, going to the gym, going for a walk, interacting, having social gatherings. There's a lot of even going to work, and a lot of people working from home now. The loss of routine affects person, and the uncertainty also affects them. Confinement, especially for elderly persons who are at home, many of them, they have lost the physical contact for sure. Many of them have lost the social contact. Certainly now as persons, children and the persons who are able are concerned about back to school issues, work issues. There may be a neglect for the elderly persons who are confined at home, who would have lost their routine and would have shared the same anxiety and fears that are associated with what's happening with the pandemic. The loss of physical activity is of particular threat to the elderly persons. And so when you ask me what it is that the Rotary Club can do, I would say that for clubs such as yours, this needs to be an emphasis. You know, I think that everybody who knows somebody that is over 60 needs to ensure that they call them, that they need to call them on a daily basis. They need to tell them to get up and exercise, to move around. They need to ensure that they have the things that they have been deprived of by being confined.
RCST is talking to Rotary.
So this is a charge that I would give to the Rotary Club, that certainly in addressing some of the issues in terms of mental health issues that in particular affect the elderly, there is something. We don't have to be mental health professionals. We don't have to be psychologists or psychiatrists. We don't have to be counselors in order to have some interaction with persons in a safe way to make them still feel loved, cared for, to help to ease their feeling of loneliness and depression. And I think that's where our focus needs to be. Certainly one of the main focus areas that we have to look at going into the management of this part of the pandemic. I would end here and I would take any questions or comments.
Thank you very much, Dr. Bissasor, for very informative presentation. I will ask PAG Mike to lead the questions, which we've asked persons to just type in the chat. PAG Mike.
Thank you, President Latoyo. Dr. Bissasor, some countries in the Caribbean, such as Cayman and Barbados, seem to be doing much better. What is the difference between us? And secondly, what is the prognosis for the future? How do we move forward?
Well, with both Cayman and Barbados, in terms of the volume of persons that we have coming into country, there has been a significant difference. Certainly, Cayman had closed their borders for a much longer period. Barbados had opened up, but have had several back and forth where that is concerned. But in terms of the volume of persons that have come into country, for Jamaica, that really has been the nidus of our infection. Our problem is that we have a lot of persons, and what we would have seen is that our problems really have lain where we have our returning Jamaicans and the Jamaicans who do not have a Jamaican passport, but that come into our communities. Many of those persons would have acted without restraint in terms of their movements, and many of these persons would have come from high-risk areas. And so we would have had some spread starting out small, which would have lain on the ground for a while, and then we would have started to see the increase in the number of cases. So it's different. I mean, we're in the same part of the world, but in terms of the traffic through country, ours have been significantly more.
Thank you, Doctor. A question has been asked retroactively. Did we make the right choice then in allowing people to come in into the island at the time at the rate they did? And should we continue that in the future?
Well, these are policy decisions that would have taken into consideration all the different areas, different stakeholder inputs. Health would have given their information, national security would have given their information, finance, tourism, education. Everybody sits at the table, and I guess, you know, the government has to take a position that balances different things. I mean, initially in May, when we brought in April, May, when we brought in our cruise ship workers, there was a lot of movement within country that we should not deny these persons entry into the country and that they should be allowed to come back in. And these remain the highest positivity rate that we've had has been from these persons. But there was a clamor because these persons would have been stuck. These are Jamaicans that would have been stuck overseas on a boat somewhere. They would have had family here that we would have received all kinds of calls and cries to have these persons to return to country. So it started out with, can you really shut out, and for how long can you shut out your fellow countrymen? Because this is how we would have started, by bringing in those Jamaicans that would have been in situations of being stranded, April, May, and then in June when we started to open up to other Jamaicans who would travel back and forth. So I don't think, or I really have to wonder how long could we have put that off. I don't have any relatives that need to travel back and forth, but somebody else, it's vital for them, you know, in terms of, you know, I don't have any relatives that were stuck overseas, you know, but we heard that people were in very dire situations. The embassies were calling us. The Jamaicans were calling them to say that we're stuck here. The embassies had to be supporting Jamaicans that were overseas in various kinds of situations. And so it would have reached to a point where it was going to burst at some point, you know, that persons would have to be allowed to travel, to return home. And so that's where it really started. In terms of the return of persons who were non-Jamaicans as of June the 15th, a lot of these persons would have been Jamaicans who would have naturalized in another country. In particular, in the US, we would have had a lot of persons with Jamaican connections who would have come into country at that period in time. So while it is that when we just started out in July, a very small percentage of what was coming in was actually tourism, most of the persons that were coming in were actually Jamaicans, residents and non-residents. So, you know, as I said, these are policy decisions and a lot of things have to be taken into consideration. But, you know, as I said, as a small country that depends heavily on travel and trade from external sources, it would, how long do you wait? And at the point, if you're not going to wait until a vaccine is developed, then at some point when you open up, we're going to be facing this kind of exponential spread.
Thank you. Thank you very much, Dr. Bissasor. We very much appreciate the fullness of your responses. Another question on the subject of vaccine. There's a report, or said to be a report, that the Prime Minister announced a trial of a vaccine in Jamaica. And another question related to that, when we do have a vaccine, how can we afford it and ensure everybody gets it?
Okay, so first of all, we do not have any vaccine trials in country. And we have not, as a matter of fact, been invited to participate in vaccine trials. It's very difficult for a small country like ours to participate in those large-scale vaccine trials that would be heavily monitored by external agencies. So we have not been invited to participate in any vaccine trials. We have not indicated an interest to participate in vaccine trials, and we're not participating in any vaccine trials. What we are participating in or hope to participate in is a solidarity trial that looks at arms of treatment for COVID-19. And it would be a trial because you would have had certain drugs that would have been used and would have been through small studies would have shown that they had some benefit, but they would not have had the benefit of full approval because the amount of knowledge for the use of these drugs was not enough in terms of the use for COVID. So these drugs would have been found to not cause any harm, first of all. And so trials would be put in place to study how it is that populations respond to these drugs. Now, anything that is done within a trial is by virtue of consent. So when a drug is approved, then as a doctor, I can just write a prescription and the person, I can, with my management of my patient, I can say to the patient, use this drug. In terms of a trial, you would have had, it has to be done under specific conditions. It has to be monitored very closely. There has to be consent of the patient to participate in a trial, knowing that this is not an approved drug, but it has been found to be beneficial, and therefore we need to have more experience with its use for it to get approval. So there would have to be that process. Now, we have indicated to WHO, we have been invited, and we have indicated an interest to participate in the trials of, in particular, remdesivir, which is an antiviral preparation that has shown some interest in, there have been few studies, small studies that have shown that it decreases length of time in hospital, but no large study as yet that has gotten the appropriate clinical review to say that, yes, enough evidence is there to show that this drug is beneficial. So it's not an approved drug, but there is enough evidence to say that we need to try, we can try this to see, because no harmful effect has been found thus far. So we have indicated an interest to participate in the remdesivir trial. However, our ethical committees have to go through the studies in detail, and we are still in a process of ethical review, because the WHO would have changed some of the criteria for the study. Our ethical committee would have done a first review, had several questions. We would have submitted these questions back to WHO, and WHO would have responded, and we are presently reviewing their responses. So while it is that we have indicated an interest, we have not yet started to participate in those trials as yet.
Thank you, Dr. Well, as you know, as Rotarians, we're very close to vaccination or polio program, but not the population is not as enlightened, we think. How will you deal with the issue of public relations to convince people to take a vaccine? Is it a big issue in Jamaica, say?
Well, we certainly have started to see the persons that are anti-vaccine showing their head already in terms of rejecting the notion of a vaccine. We've had this experience, I mean, certainly in terms of our HPV vaccine introduction in schools, we've had some negative feedback in terms of persons not wanting to have their kids being vaccinated. Even with the flu vaccine, every year we have the flu vaccine, the take-up for the flu vaccine is very low. And now that COVID is topical, a lot of persons are looking to the development of a vaccine. We can't be sure what is going to be the take-up in Jamaica. We would have already started the development of our program in terms of our implementation plan, which would heavily be focused on health communication and promotion of the vaccine and the uses and benefits of the vaccine. It's difficult sometimes to start these programs when the vaccine is not yet developed. And so we don't know what type of vaccine. There are several different types of vaccines that are out there. Persons are going to want to know what type of vaccine. Is it a part of the virus? Is it an inactivated virus? Is it some other thing that is stimulating the response? So you want to have some of those answers in order to be able to alleviate any fears that persons would have. So we do have an implementation plan that we're working on. In terms of the communication aspects, the development of that, but we will have to wait until closer to find out exactly what the vaccine is before we start rolling out. However, in terms of procurement, we would have indicated that we would want to be a part of the WHO PAHO's plan of procurement of vaccines for countries. And so Jamaica has given a commitment in terms of the procurement of vaccines through that facility, and that would be a phased approach where initially countries would have up between 10 to 50% they can commit to purchasing in a first phase, and most countries would be between 10 and 20% that they would commit to procure, and then in the other phases, and this would hold us to a certain price. And then after that, then we'll be able to procure more. So in terms of our first rollout of vaccine, once it becomes available, and once we have it here in country, we would be looking at the high-risk groups, just as the same plan that we use for influenza. That's the same plan initially that we would roll out in terms of the high-risk groups, frontline workers, the elderly persons, persons who are more at risk for severe disease. So that would be the first set of persons, 10 to 20% of the population that we would be looking at to roll out the vaccine to. We will see what our take-up rate is like, and then all of that would now determine how it is that we proceed in terms of the procurement of more vaccines.
Thank you so much, Doctor. I know you don't like to comment on individual cases, but there is a case of a one-day-old baby contracting the virus. And the question was, did it happen before birth, or did the baby contract it afterwards? Is there a possibility that a mother could, while being pregnant, give her child the virus?
I'm going to say that I have not seen any. I know very, very early in the first few months of the of the management of the pandemic, we would have seen studies that would have said that there was no evidence of mother-to-child transmission. I do not know if there is any latest information on this. It has not been brought to my attention that there is any evidence of mother-to-child transmission through the placenta, that is. But I really don't know. For the last month, I've not really been checking on that particular those particular reports. So I don't know if anything has changed lately. However, it is possible for the mother to transmit to the baby because they're in close contact if mother is infected at the time of the baby's birth and mother is close to the baby. So there is the chance of transmission to the baby. The baby would be in an immunocompromised state, and so therefore the viral load of the mother and how much virus the baby is exposed to, I would believe that all of those would have an impact in how likely it is that the baby would contract this disease. Then we also have to consider that the baby passes through the birth canal. The virus is picked up through nasal and oropharyngeal swabbing. And so we have to wonder, is it that the baby was infected in that the baby had multiplication of virus within the child's own system, or does the child have fluids in its nasal or oropharyngeal cavity that could have come from the mom, resulting in a positive test so very early in the child's life? All of those are possibilities. I would have to review the latest data in terms of evidence of transplacental movement of the virus, but that would be my comment right now.
Thank you, Doctor. There's a question about, we do acknowledge the excellent statistics the Ministry of Health puts on their website and the daily updates. There's a question about, is there a lag in the confirmed cases?
In terms of our reporting?
Yes, in terms of reporting.
Well, I can tell you and all the Rotarians that we really have absolutely no reason to hold back the results. As we get them, we put them out. The results, we're not even so much involved in the process of, there isn't any chance of manipulation by the Ministry of Health and Wellness, because as soon as the tests are done, the results come to us, and they come to us between starting for what we would report today would come to us starting from last night. The batches will be run in the night. By morning, they're off. We start disseminating to the care facilities right away, even before we get all the batches in. By 3 o'clock each day, we cut off on the number of batches that we are going to be reporting that day. We do our tally so that we can have our report ready for submission, so that the epidemiology unit now would have to investigate those cases to see what category they fall into, if they're contacts, if they're coming out of respiratory surveillance, what was the reason for the testing, so that we can give some report, look at the notification, look at the age, look at the parish. That process takes some time for them, and they have to start from very early in order to be able to get a report ready to put on the website by 10 o'clock the next morning. So as soon as we get the results, they are released. What we have, you will notice that we would have cases under investigation. Many times the notifications for the test don't come in. And so it's difficult for us to be able to say for sure that this is a contact, this is an imported case, or this falls into some other category. because we just don't have enough information. And so those cases fall under investigation. Same thing happened with deaths. You would have noticed that we would also have deaths under investigation because we would get the notification of the death. However, we now have to get the case notes from the hospital. We have to review the information to see when the person died, when did they do the test, did this person die of something else? Because while it is that, you know, as we say, COVID is keeping, all the other diseases are still keeping. And so persons are dying from strokes, from heart attacks, from trauma. We still have those deaths that are occurring, but because we're in a community transmission phase, we test those persons post-mortem, many of them, as soon as they come in to hospital, the critically ill persons, they're tested. So even though somebody may have a stroke and they may pass, we would have tested them, and it just so happens that they are COVID positive, but this was not the cause of death. So that's when we have the coincidental deaths. So the investigation does take some time for us to get all the information. Sometimes we don't have enough information because the person died within 24 hours of coming into hospital. Some persons we have brought in dead. So we have to contact the families to find out what happened to this person. Were they ill? Did they have any kind of respiratory illness, any fever, any evidence of any viral illness? Do they have comorbidities? Do they have anything suggestive, you know, any chest pain, any kind of weakness, anything, you know, that would suggest what was going on to them? So it does take a little time, and we try not to put out and have to pull back, because that becomes a problem and our credibility comes under question when we do that. So it's better we keep the cases under investigation until we know exactly what's happening, but we put out the overall numbers, you know, as we get them.
Thank you so much, Doctor. Your answers are so helpful to us. A question, there's this thing called the positivity rate, which I ask you to explain to me. What do you think of it over the last month? And how prepared are we for moving forward with the opening of school and moving ahead?
Okay, I heard a comment today on, not today, 2 days ago on Nationwide that, you know, I kind of cringed when I heard it because it was just the wrong interpretation of the data. Because when we speak about the positivity rate in terms of it's being used as an indicator. So this person had indicated that it was an indicator for below 5% you would want to be before you go back to school. But we were presently in the 20s in terms of our positivity rate. Okay, but it's two different positivity rates that were being talked about. You have the cumulative positivity rate, which is the overall positivity rate that we're actually at 7.7%. So we have maintained pretty good below 5%, actually below 3% for quite a long time. And now we have gone above that 5% to 7.7%. So that is the value that should be looked at. It's a cumulative positivity rate that is looked at when you're using it as an indicator like that. So it is true that we're not at 5% in terms of that cumulative positivity rate. We're at about 7.7%. And what the positivity rate also has been an indicator for is the level of testing within a country, to say if your testing is adequate. And so if your testing is below 5%, then they say you are testing adequately. So having gone to 7.7%, certainly we have examined that over the last couple of weeks. We've had constraints with testing. We have said it in our public forums that we've had difficulty getting in the supplies, and this has been a major challenge over time. Every day we have to be fighting at it to ensure that we have supplies in country. So over the last couple of weeks, we've had a little bit of challenge in terms of getting into supplies. However, I think we're in a better position at this time to be able to consistently keep our testing at least above 600. We are able. So I don't foresee us falling down to the 300. And I have to keep my fingers crossed every time I say these things, because I know when it happens, then people say, oh my God, you said that we would not reach here. But we are hoping that we can consistently keep our testing level above 600 per day, which is almost at almost 5,000 per week test. And we are hopeful that we are able to get it up from there to between 800 to 1,000 regularly. Now, this would be able to, with that testing level, we should be able to get back our positivity rate below 5%. So we would have identified the areas where we would have seen that we would have needed to increase this testing, and we have been working with the health departments to get this done. And certainly over the next couple of days, we had a large amount of supplies of the transport media and swab coming in last week, which was a major deterrent for us. So we had over 20,000 of those coming in last week, which would be able to get back our testing or sampling up to get that below the 5% that everybody would like to see us at. Now, the 24% and the 27% is the weekly positivity rate. And certainly that gives us an indication of what is happening, but it really is the cumulative positivity rate that we use as those indicators.
How prepared do you think we are for school ahead?
I think that I would want to leave that for the Ministry of Education to comment on. I know that there's going to be a program this evening on, I think it's TVJ, and I would, invite everybody to listen to that to get an idea in terms of our preparation. I have not been involved so much in these last couple of discussions that we've had, but I know the discussions have been taking place, and I'm sure that in this evening's presentation, the country would be a little bit clearer in terms of what's happening for the opening of school.
Great. We do appreciate how detailed you are with your answers and the patience you take. You're a very good explainer. On the question of testing, right? Are we only testing people with symptoms? And somebody asked the question, when someone is tested, how does the ministry communicate back with that person? Right? There's stories that people don't hear back for some time. What is the protocol?
So I recognize the challenges we've had where this is concerned. I'll take the first question first in terms of the testing of symptomatic persons. Now, the testing of who we choose to test is really dependent on the phase of transmission that we are in, because testing for us from a public health perspective determine what are your public health interventions. So for us at this point at the Ministry of Health, is the trends in the testing that's important. The overall testing result guides the public health intervention. So at this time, we want to see if our numbers are going up or numbers are going down or if we're stabilizing, because that determines what our interventions are. The public health interventions are no longer focused on an individual's test. So from a public health perspective, we are more interested in the overall numbers. In terms of community transmission, the likelihood of persons being positive is very, very high. And so therefore, if somebody is positive and we do contact tracing around them, if it is that we pick up one symptomatic person around them and that person is tested positive, I don't have to test the whole entire household anymore. I know there's a problem. So the intervention is based more on an overall picture rather than an individual. When we were in the earlier phases, every positive was important because every positive needed to be separated from the rest of the population to prevent contamination of the population. Every single positive, we took them and we put them in a room by themselves. If they couldn't do it in their house, we took them into a facility and did that for them. Now, the likelihood of a person becoming infected in any setting is the same. And so therefore, individual testing is not so important for us. We want to know if a workplace, if you have a positive person in a workplace and there is 1 or 2 symptomatic persons in that workplace and there's a positive, there's a problem there. I don't have to test every individual to tell me that there is a problem there, okay? So our intervention at that workplace is going to be dependent on that. It doesn't take every single soul to be tested because in community phase, in community transmission phase, our assumption is that everybody is positive and whatever measures you have must be sufficient to protect you if the person who is working in the same office as you are is positive. You know, one of the big problems is that person put in a lot of measures and they put in these measures to protect them from persons who are not positive, to the point that when they find out that the person is next to them is positive, they're, oh my God, the world has come to an end. But what were your measures for? It was not to protect you from somebody who was not positive. It's to protect you from somebody who is positive. So it has to be sufficient. And that is a message that we need for people to carry. Your measures need to be sufficient. You should not have to go and close a business place because one person is positive. Because everybody in that business place should be wearing a mask, should be physical distancing, should be using hand hygiene, respiratory hygiene measures. There should be adequate cleaning measures in that workplace to ensure that this virus that is so very easily killed the surfaces are cleaned on a regular basis. The area is wiped out with ordinary soap and water. The floors are mopped. Regular cleaning measures take place on a regular basis. These have to be sufficient. This is the only way that we're going to move forward. We cannot wait until we say that, oh, we have a positive person. Now you're going to look back and say, my measures were not sufficient. That's not good enough. Workplaces now have to put in measures that are sufficient. And it's not just workplaces, our hospitals. The greatest alarm to me was that a ward was closing down because they had a positive patient to sanitize. My God, this ward is supposed to be cleaned every day to protect you against HIV, tuberculosis, every single pathogen that is so much more resistance than coronavirus. Why do I now have to close down a ward or an operating theater, which is supposed to be a sterile environment? Why do I need to clean it down to clean for COVID? My cleaning measures should be sufficient to protect me. And this is what we have to understand, sufficiency of our measures and therefore the necessity. So testing is for case management. So the doctor that is managing a patient wants to know if that person is positive. So it's for case management, it's for outbreak detection. So if I have a new case, I'm going to test around that case to see if I have a problem in this part of the country that have never had a problem before. Testing are for those purposes now. There is no point again to test everybody because guess what? Everybody has COVID.
Thank you so much, Doctor. I'm going to pass you back to President Latoyo, but I can understand why our past district governor, Dr. Paul Brown, thought you would be an excellent person to educate us on these subjects. Right, thank you. President Latoya.
President Latoya,
hold on.
President Latoya, just one question for Dr. Bissasor. What are is there a new protocol when you travel back from the US to Jamaica? you still have to do your 2 weeks quarantine?
Yes, you still have to do your 2 weeks quarantine, because one thing that does not change or has not changed yet is the incubation period of the virus. So that still remains at 14 days. So even if you test now, you still have to be observed for 14 days, because during that period, you may develop symptoms and you would need to be tested at that time.
Thank you very much, Dr. Bissasor.
All right. Thank you very much, Dr. Bissasor. I think we would have exhausted all the questions in the chat. And I think your answers were very detailed. You have always been a detailed person and you have been consistent. So we're happy for that. So I think most persons' questions have been answered. So at this point in time, we want to turn over to President Novlet, who will move the vote of thanks on our behalf.
Thank you very much, President Latoya. Dr. Bissasor-McKenzie, thank you very much for having a very, I think, excellent bedside manner. You brought that and that objectivity to your talk this evening. And the way you explained where we started to where we are, it gave us a very, I think, clear picture of how we came to be where we are. And not only did you do that, you explained what the different phases were like and what it meant to be there. And the whole business of the public education and the public practices out there, you have been very detailed here with us. I am hoping that the way that you have managed to bring it over to us, that somehow we can have, you know, that kind of drilling down across various communities, not just to a small group of Rotarians, because I must confess that, you know, in general meetings of press conferences or so, maybe some of these details get lost in translation. So I am hoping that as we continue to handle this pandemic and the various consequences that we face, that your calm leadership in this area will continue to enlighten us and to support all the efforts that are being made. On behalf of all the Rotarians here present, thank you very much for a very, very excellent presentation. I've seen some of the comments in the chat, and people are really impressed with the answers that you gave, and they have left enlightened. We really want this type of education to be spread and shared, and I think that the Rotarians here present are equipped to share some of the very excellent information that they have received. I'd also like to take the opportunity to thank the Rotary Club of Spanish Town and its leadership for organizing such an informative evening, and for all the persons who have worked with you, say Spanish Town, to make this evening's event, I think, a well-worthy and worthwhile one. Thank you again, Dr. Bissasor, and thank you very much to all Rotarians here present, and especially Rotary Club of Spanish Town. Thank you.
Thank you.
Thank you very much, President Novlet. And I see we have 59 participants. Certainly this is the largest meeting that we've had since the start of the Rotary year. And of course, it couldn't have been done without all the persons that are present, the PDGs, the PAGs, everybody that's here, and also the guests that came out to listen to this very informative presentation. So at this point in time, we will ask PAG Mike to bring our meeting to a close. PAG Mike, we'll ask you to bring our meeting to a close by proposing a toast to the club of your choice and RI, and also to lead us in the national anthem.
Thank you, President Latoya. Fellow Rotarians, join me in a toast to the Rotary Clubs of Jamaica Central, Spanish Town, Portmore, North St. Catherine, and the great Rotary Club of Manor Park, and Rotary International.
Here.
At this point in time, he'll lead us in the national anthem, which will be an instrumental. Thanks, everyone. And we hope that everyone will keep safe. It was indeed a good meeting. So enjoy the rest of the evening.
Thank you.
Thank you.
Safe,
Thank
everyone.
you, Latoya. Thanks.
Thank
Bye.
you. Bye-bye.
Bye.
Hi, Dharma.
Bye, everyone.
Thanks, everyone. Have a good night.
You too. Latoya, thank you.
You're welcome. It was nice having you.
Thanks for inviting us.
Good to see so many Rotarians. Yes. Is that PP David? Hi.
Wonderful evening. Very good
yes.